everyone. A very warm welcome to one and all. I am Dr. Shweta Surve from the Medical Affairs team of AstraZeneca. And on behalf of AstraZeneca, I would like to welcome you all for today's experience sharing discussion. The next 1.5 hour, we would be discussing on the real world experience of management with ibrutinib and acalabrutinib. But before we begin today's session, I would like to welcome our program director, Dr. M.B. Agarwal, sir, for opening the session and introducing everyone. Sir needs no introduction. He is a very well-known personality in the field of hematology with decades of experience, and he's also a professor and consultant and head of Department of Hematology at Bombay Hospital, Mumbai, and consultant at Leelavati Hospital. So without much ado, I would like to hand it over to Dr. Agarwal. Over to you, sir.
Thank you, Dr. Shweta, for putting all of us together for this wonderful evening and discussing the role of BTKIs today. The first part of the session will be moderated by Dr. N.V. Ramaswamy. It's on my clinical experience with ibrutinib, and the panelists include Dr. Unni Pillai, Dr. Nishad Dhakate, and Dr. Nikhil Krishna. So Dr. Ramaswamy, over to you.
Thank you very much, sir. So can you share the slides? And I just would like to share one of the patients with ibrutinib. He's a 17p deletions with a TP53 also, and also along with that 13q deletions, along with hepatitis B, HBsAg reactivations while on CLL without therapy. So this is the case I would like to present. Go to the next slide. Yeah. So this is a 68-year-old gentleman, a known diabetic on oral hypoglycemic agent. And a year ago, he had a fall, followed which he had a backache, and MRI was done, and conservative management was carried on. During that evaluation, ultrasound showed that MRI evaluation that liver was found to have a cirrhosis features, and a workup showed HBsAg positive, but the virus was not detectable. And then with this, he was on regular follow-up. And the current symptoms goes with the complaining of abdominal pain along with abdominal fullness, and also seems to be loss of weight as well as loss of appetite. He had associated constipation. He also gives history of breathing difficulty when he's lying down. With this, he went to the local hospital, and ultrasound showed evidence of hepatomegaly as well as Cori lymphoma with elevated blood counts, referred for further evaluation. With the next slide, please. An examination is found to have a generalized lymphadenopathy, both bilateral, cervical, axial, inguinal, and less than 3 centimeters in each side. And examination on the chest is normal, and the spleen was found to be 5 centimeters below the costal margin. The liver was not palpable, and the CBC showed evidence of total count of 4 lakh with hemoglobin 9.7 and the platelets 90. There is no evidence. The peripheral smear shows large lymphoid cells, monomorphic cells, but there are some atypical cells which showing a nucleoli 8%. And a lot of SMET cells were seen in the background, and the LDH was 503. Tumor lysis, TLS markers were negative. So because the patient is having a pancytopenia, we thought that we will do the bone marrow to know that what is the status, if it is going to be the CLL or any other leukemia. Is it acute leukemia? Because 1 year back, there was no evidence suggestive of the same. So in view of this, we did the bone marrow too, not only confined to the peripheral blood flow cytometry, and also that, next slide, please. And also the lymph node biopsy also, because we thought that because of the loss of weight, loss of appetite, and the LDH was very high, is this a Richter transformation also was thought of. So in view of this, even though it is not straightforward cases, does not need any lymph node biopsy, or it does not need a bone marrow. Of course, it is needed for sometimes for the intertubulars or of a diffuse or of a focalized infiltration. So MRI done in view of the low backache, and it will show a diffuse marrow infiltrative process. Ultrasound evidence shows evidence of chronic parenchymal liver diseases with moderate splenomegaly. Next slide, please. The FDG showed evidence of low uptake throughout the glands, as well as the splenomegaly and also hepatomegaly. And there was a compression fracture at the D12 vertebra, possibility of osteoporotic in nature. Next slide, please. So the bone marrow was done, which shows typical of that small monomorphic cells, and the rest of the parameters were unremarkable. The rest of the lineage hematopoiesis like erythroid and myeloid and megakaryocytes were decreased. And bone marrow biopsy shows evidence of complete replacement, diffuse infiltration by the 100% monomorphic cells. Next slide, please. And the peripheral blood flow cytometry was classical of CLL score of 5 out of 5. And the karyotyping on the bone marrow was carried out showed evidence of complex karyotyping, and the FISH shows evidence of TP53 deletions in 76.5% and chromo along with 13q deletion in 69%. So the final impression by the FISH was showing a positive for deletion 13q as well as TP53 deletions. Next slide. And the lymph node biopsy was carried out in view of this possibility of wrist translation with the constitutional symptoms as well as a high LDH. But the features were suggestive of a chronic lymphoproliferative low-grade lymphoma, CLL, consistent with the CLL. And the proliferation index was only 20 to 25%. There is no evidence of large cell transformation. Next slide, please. So with this, what we have done is, because the patient was, the viral load was done because he's a known HBsAg positive. So the viral load was somewhere around 5,56,000, for which the hepatology consultation was sought, and he was started on entecavir initially. And subsequently, to control the disease of the CLL, we have started with the chlorambucil, 10 milligram, the typical course of 10 days a month course was started. And then with that, the count has come down from 407 to 207 after the next month. So during this time, that viral load has also started coming down. And after 2 cycles, the viral load has become negative. After 3 months, the viral load has become negative. And after 2 cycles of the chlorambucil, the counts has come back to 100. And the hemoglobin was maintaining around the 9 to 10. And the platelet was maintaining at around the 90 to 100. So at this point of time, because of the 17q deletions, initially to avoid the tumor flare as well as the tumor lysis, and to reduce the bulking of the disease, we have given the chlorambucil. After that, it was discussed because of the 13q deletions. It was started on ibrutinib. Initially, for the first 1 week, 2 tablets. Once he started tolerating, the tablet was increased to the proper appropriate standard dose, and then he was continued on down. Fortunately, he never had any tumor flare, or he did not have any musculoskeletal joint symptoms, and hemodynamical instability was not there. There was no bleeding. And for the past 1 year and 5 months, he is on ibrutinib. He was once in 3 months follow-up is going on. Only once he was hospitalized for the hyponatremia 6 months back, the cause of which is not known, but within a day he has recovered, and at present he is continuing fine. Because of the 17q deletions, a poor response to standard immunochemotherapy, and the drug of choice is the ibrutinib for the standard care at this point of time. He is currently on. Fortunately, he did not have any other side effects of the medications, so he is doing fine. With this, I am winding up, opening up for the discussions.
We have Dr. Unni Pillai, Dr. Nishad, Dr. Nikhil for your remarks.
So, Dr. Agarwal, sir is muted.
No, can you hear me? Can you hear me?
Yeah, yes, sir.
Yeah. So we have Dr. Unni Pillai, Dr. Nishad, and Dr. Nikhil for their comments on this case.
Sir, I was just wondering, Nishad here, so I was just wondering whether we could have started ibrutinib upfront for this patient.
Yeah, the possibility for 2-3 reasons. One, the count was already on the higher side. 2, he was having the hepatitis B DNA load of 5,56,000, and it has become negative after entecavir therapy of 3 months. So we does not want to flare up of the hepatitis B. What is the scenario? We were not sure about that. And the total, the count was also high because everywhere generally is lymphadenopathy. We don't want to have this one tumor flare or anything for that. And also mainly because of the hepatitis B infection, we are a bit concerned. So that's the reason we just started with the chlorambucil only. We waited. Once we come to know that it is okay. So we started probably within only 2 cycles of chlorambucil was given. After that, ibrutinib was given. And for the past every 3 months, we are doing the viral workup, and so far it is negative. Initially, he was on entecavir, followed by tenofovir. It was changed to tenofovir. There is no difference between this one. Initially, the physician started with the entecavir. After that, the long-term entecavir can cause a viral resistance. That's why they changed over to the tenofovir. Currently, is on tenofovir as a for the hepatitis B infection purpose. So basically for the evidence of the hepatitis B.
Yes, sir.
Dr. Uni, your comments?
Nothing, sir. I'm okay with the management except for the fact that I would have started ibrutinib from the day one itself with the 17p deletion along with the entecavir. So other than that, nothing much to add from my side.
Right. Dr.
And
Nikhil.
hopefully the patient is doing well. So
Yeah, patient is doing well. Nikhil?
Yes, sir. I mean, I have nothing more to, again, as Ramaswamy sir, reasoning for starting chlorambucil is something I might also actually agree with. And that is something in a certain cases I've done. But then if the patient otherwise was stable, we generally start with ibrutinib. And of course, monotherapy with ibrutinib. Otherwise, it seems fine. I mean, managing the viral load becomes an issue in these patients. And even in a later therapy, adding an CD20 therapy to these patients become the trick, or that will be the how to manage them will be the trick. So monotherapy, the ibrutinib would be the standard of care, sir, with the P53 mutation.
Right. Dr. Ramaswamy, did he have any problem with ibrutinib in these 5 years?
Fortunately, he never had either the musculoskeletal or a cardiac or a hemostasis, none of this, and also hepatitis B.
Right. And did he have any other comorbidities besides liver?
Yeah, he never had a we were following up with a hypertension building up or anything in the clinical scenario. He did not have any hypertension too. And where the sugar is being controlled, sometimes it was fluctuating, and it was under the diabetologist follow-up.
Right. Cardiac wise, he was normal.
Yeah, it was normal.
Right. The rest of the colleagues, if anybody wants to comment anything before we move on to the second part of the discussion today. Okay. Fine. Did you do IGHV mutation status?
We are till now we are not doing the IGHV mutations. Probably now there are a lot of they are coming up with this one the same. Our Astra itself is coming forward to do all this testing. Probably we will be incorporating for the subsequent patients.
Fair enough. So should we wind up this case and move on? All are okay. May I invite Dr. Prashant Parmeshwara for the second?
Hello.
One question.
Dr. Agarwal?
Yes.
Sir, just got the update in this next panel discussion, which Dr. Prashant is moderating. Dr. Vinay Bora and other doctor is not able to join due to some emergency. So it will be continued by Dr. Unni and Dr. Nikhil.
Sure.
They will be there.
Sure.
The one of the reason for not doing the IGVG mutation, already we got a 17p deletions. That is equally bad one as far as the outcome is concerned, and we know that is the only ibrutinib is the choice for those, whether it is a mutated or unmutated, and also 17p deletion. One of the reason that we didn't do that, of course, for not availability and the cost.
Fair. Absolutely fine. Yes, Dr. Prashant, go ahead.
All right, sir. Can you hear me?
Yes.
Respected seniors. So basically, this experience is basically to understand from your practice how has been this drug ibrutinib to all of you. So this patient is a 70-year-old male who is a diabetic and hypertensive. Hypertensive for around 20 years. Was diagnosed with CLL 5 years back. And at that time, he had a thrombocytopenia, and we wanted to treat, and we gave chemotherapy. BR was given. Then he presented again. At that time, the TK was not that famous, I will tell. So he presented again now with fatigue and weight loss. Flow cytometry confirmed CLL. He had a normal FISH, unmutated IGHV. His total count was 1.7 lakhs with 95% lymphocytes, hemoglobin of 10.2, and platelet 84,000. So this patient was started on 420 milligram of ibrutinib daily. He responded very well with decrease in the lymph node size, transient leukocytosis, and after that resolution of all his symptoms. fatigue improved. However, the main issue which we're facing was basically in the form of increase in blood pressure, which are not controlled by dual antihypertensive agents. And as a third antihypertensive, we had to start on thiazides also. He was on telmisartan, then a calcium channel blocker of amlodipine, and after that a thiazide, and he had severe muscle cramps. Muscle cramps can be due to ibrutinib, or it can be due to this thiazides also. And this patient has been started on acalabrutinib, 100 milligram BD. So this was done basically because of two different classes of antihypertensives. And then the patient is responding well to the new BTK and he is adhering and compliant. This is that guideline. If you see BTK inhibitors are class 1 in any of the indications you take. So the experience from the DIAS basically in the form of hypertension management in people with ibrutinib, and to an extent atrial fibrillation can also be discussed. Over to the discussing panelist. Over to you, sir.
Okay, so as we don't have Dr. Vinay and Dr. Nilesh, Dr. Unni and Dr. Nikhil are going to discuss, right? Dr. Unni, your remarks.
We do come across with hypertension and we do manage with the calcium channel blockers, ARBs, and beta blockers. Our cocktail will be to add Concor, that is bisoprolol, that is what we use first, followed by losartan, and then we add one of the calcium channel blockers. So, and we are happy with that, and we don't have, most of our patients do get good blood pressure control with this regimen, and we never changed the drug because of uncontrolled hypertension or muscle pain. And luckily, so far, we have not come across with the atrial fibrillation. It's well documented that in those patients with the cardiovascular issues, acalabrutinib will be a better drug than ibrutinib, but we are managing with the ibrutinib so far very well.
Thank you. Dr. Nikhil?
My apologies, sir. I just got a call from the hospital.
Oh, it's fine. It's fine. Others want to comment in the management of this patient?
Nikhil, I will tell again, the story is he is having an uncontrolled hypertension with ibrutinib. So have you got any experience of this uncontrolled hypertension?
Sir, Dr. Nikhil just got logged out. What he said.
All right,
he
all
got
right.
Call from the hospital.
Agarwal sir can take over. No problem.
Okay, so hypertension with ibrutinib is a common phenomenon. And unfortunately, this is one complication which keeps increasing with the duration of ibrutinib therapy. So even if the first 6 months, 1 year, 2 year go without hypertension, it can keep coming up at later stage, 3rd, 4th, 5th year. And I mean, most of the time we take help of the cardiologist in managing it. It has not been difficult to manage the hypertension. And as was said clearly, that you almost never have to give up or change the medication because of hypertension. Most of the time, almost invariably so far, we have been able to manage it with the help of drugs. So it's common. It comes up anytime, even during 2nd, 3rd, 4th, 5th year of the therapy, and it is manageable. Any other remarks by anybody, even if you are not a part of this particular case discussion? Yeah.
Regarding the current scenario of the hypertension status after the acalabrutinib, because that too that can happen with even with that also. So whether you are able to tide over it, or whether it is still requiring a 2 or 3 antihypertensive.
That's a question to Prashant.
No.
Yes.
As of now, he is well controlled. That means with 3 hypertensives, the target blood pressure which I am aiming is 140 or 150. He's not getting less than 140. But still, he's okay. Muscle cramps was one of the main concern, which muscle cramps has improved.
Yeah, that might have improved, but because the hypertension is known to both the drug,
that
it
is
may
true.
be lesser in incidence. If the patient does have it, chances of having with the other molecules is also there.
That is true.
Okay. So if there are no other remarks, we move on to the third case presentation, and that's by Dr. Mobin Paul. This is about his
1 minute, Dr. Agarwal.
Yeah.
Yes, in that study of changeover for those who had tolerance issues to ibrutinib, and when they were switched over to Ecala, I think about 10-15% were due to hypertension in that study. If I don't know if somebody remembers that number, that one of the important reasons for changing was hypertension.
I'm not sure about the numbers, but one thing is there, sir. The landmark study of ibrutinib, even the post-marketing, all the data from MSKC and everything shows that the incidence of hypertension is very high. It is almost invariably 80 to 85% is the hypertension with ibrutinib. So managing hypertension should be taken seriously while you put on ibrutinib.
Any other discussion?
Apart from hypertension, what about skin toxicities and what about pulmonary toxicities? We have few patients who developed pulmonary aspergillosis while on ibrutinib. Almost everyone develops skin nodules, itching, and skin toxicities. And Prashant, your opinion on that?
We had two patients with fungal this thing only with ibrutinib. We had a bad experience. Basically, one of our patients succumbed also, but he was actually we were losing him anyway. He was having a Richter's this thing, not responding to chemo, and after that with ibrutinib he had a fungal pneumonia and we lost him. But I agree, the chance of infection rates are more with ibrutinib. Skin is usually tolerable. I feel that skin has been tolerable in my practice.
We also
Sir,
had
what are
one nocardia on very well controlled CLL, nocardia on ibrutinib. But I of course don't have a comparison versus Ecala, but as per the data, I think it's supposed to be same, except this few other tolerance issues, hypertension, at least the data on trials is same. So maybe as we have more experience, we'll know with Ecala also what's the incidence. But,
Prashant, what are the three antihypertensive? Thiazide?
Calcium channel blocker, telmisartan, and thiazides. Because if you look at the JNC, this thing, antihypertensive classification, now thiazides has come first. You have to expose them to thiazide. That was what my cardiologist was telling. Even though you are telling beta blocker and other things, thiazide should be in the part of this thing. So the muscle cramps are becoming a big issue actually.
Any other comments? Okay.
Most of the patients who are under fungal infections, is it only on ibrutinib or they were on other molecules also? Or they might have received the previously any other therapy, it is a salvage or second line therapy. Yeah, upfront ibrutinib, yes, of course, we can cause, it's not that. So any other, that all these, whoever has commented on that, are they only on ibrutinib upfront without any co-molecules, or was it they received previously, it's as a second line?
Upfront ibrutinib, sir, upfront ibrutinib, no other immunosuppressants. And when we went back and checked, it's well written, well documented, toxicity, especially aspergillus infection while on ibrutinib is very well documented, and it's a major issue. We have one patient we managed with voriconazole and the patient came out, and
I agree. Even with pneumocystis carinii is documented. And I think so, that analysis showed that exposure to steroids, previous exposure to steroids and another anti-neoplastic therapy actually precipitates this more when you expose them to ibrutinib also. But
it has been shown upfront very clearly, data were seen.
Yeah.
But most of the time it is, as Prashant is considered concurrent. That.
So we're talking about tolerance issues on ibrutinib, right? So one of the peculiar issue we had was a severe anorexia and he was losing weight because of that. We did extensive workup, no infection, this, that, scans. So finally, we reduced the dose, and with that, his appetite improved. We in fact even put him on antidepressants after all the infection workup, every other workup. Nothing worked. Reducing the dose to 1 actually per day, and then as he improved, we took him to 2 per day, and then now we are maintaining him on 2 ibrutinib per day, and with that he's fine. If anybody has had that kind of systemic issue, we have not had any aspergillus, luckily. So only one nocardia and this one hemorrhage, multiple ecchymosis all over, very scary, and patient was, absolutely clear he's not taking it again.
So what did you do with that guy who refused to take it?
So that time we did not have Acala. So we went on to, I believe, that high dose methylprednisone and rituximab, which was many years ago.
Was he on antiplatelet agents?
Sorry?
Was he on antiplatelet agents?
I don't remember offhand, but most likely no, but it's 5 years plus. So
Sir, given the rate of infections, do anyone of you feel that these patients should be placed on like antiviral, anti-PCP, or maybe antifungal prophylaxis along with ibrutinib?
They are not doing it routinely either on trial or off trial, as many people as I've spoken to the international faculty. It is also not part of the new trials that I know of.
One of my patients had severe tinnitus and vertigo after starting ibrutinib, and I had ruled out all other causes. I don't know if any of you experienced such side effect.
Without hypertension?
Yeah, without hypertension and without atrial fibrillation. He just had tinnitus, and that really started after ibrutinib. We worked him up for all other causes, even got a kind of MRI done, and we could find nothing.
Any cardiac side effects anybody has seen?
Atrial fibrillation.
No, I mean coronary artery disease, IHD.
Oh,
my first patient, I don't know what happened, but she died within 2 months. They were giving this, I think, 1 + 1 month free refill. So at that time, she had come in for first time to see us. They took it for 1 month. The elderly lady, they were very happy that very good tolerance. So they took this refill directly from the pharma, from the distributor. And after during the second month, she had some sudden event and died.
Anything?
So I'll just please go ahead, sir. Sir.
Yeah. So yes, of course, the ibrutinib, there are data, the anecdotal report showing even that not only the atrial but also the ventricular tachycardia calamity has happened in a normal person who has received. So maybe the possibilities, we are not saying if there is no time between that for a rescue timing, probably ventricular events rather than the atrial events, possibility is there. And this one of the possible advantage of the accelerator is that the ventricular events is not being till now is reported as far as Acala is concerned. Maybe the things. So definitely we all know that it may be a maybe the thing possibilities of arrhythmogenic probabilities. And if it is succumbing immediately without time bound, probably ventricular etiology has to be thought of, which has been reported with ibrutinib.
Right.
Any other discussion? So then we invite Dr. Mobin Paul for his case.
Thank you, sir. Very good. Good evening to all. Mine is a short, small case presentation. Can you put the slide? It's an 8-year-old gentleman, retired professor. He had diabetes, hypertension on medicines for 10 years, well controlled. 2011, he had a coronary event which has been managed with stenting. And his ELL was 10 years on follow-up. During the COVID time, his follow-ups were, less frequent. Then he presented to us with anemia, anemic symptoms. Hemoglobin was 6.1, count was 1.43 lakhs with a normal platelet, raised LDH with borderline uric acid. So counseled and initiated because of the advanced stage and coronary and multiple other comorbidities, started on acalabrutinib. And that he had developed complications a few days down on 18th. He had a chest event and chest pain, which was documented as NSTEMI, angio short ripple vessel disease with advanced age. They done stenting to both RC and LCX. Started on a dual antiplatelet on the same day. They gone through a radial artery puncture. But next day, he had minimal swelling over the left lower limb. He had a unprovoked left proximal DVT. And along with that, he was initiated on anticoagulants along with the antiplatelet for this stent. Then very next day onwards, he started having hematuria, which forced us to put a IVC filter. He stabilized over next 2 weeks and discharged. But he again presented a week later. He came for a review a week later. He was fine. In a week later, he again came to emergency with a massive hematemesis, cardiac arrest. Revived, but he had a significant hypoischemic encephalopathy. Later, come to disease. Sir, MBA sir, I'm done. Hello.
Okay. So, Dr. Abhijit Baheti, you want to discuss this case?
Yes, sir. Actually, this we can always attribute this problem to the drugs, but there are many other like confounding factors because of age, and the person may be underlying cardiac problem. They might have precipitated this.
Yes.
So drug is always one of the
drug. Yeah. It was all happened one day after another, one after another tragedy. So, yes.
Right. These drugs themselves are, yeah. Yes, Abhijit.
DVT, Abhijit is just like entry radial puncture. They did this PT, everything. But very next day he was in CCU morning. We noticed having swelling. He was complaining of pain. Just for a completion of workup, it was not obvious edema and all. We did a Doppler which showed acute, acute deep venous thrombosis. I don't know which way to explain. Both sides it was happening.
Yeah, it's very difficult to pinpoint, but the only thing like you started the drug and this event happened. So we are attributing towards the possible, very high
No,
possibility.
I'm not attributing to drug at all. As you suggested, I don't know. Maybe it's just it just by bystander phenomenon. It just happened over 1 week. Tuck, tuck, tuck. Every day we were giving family one after another bad news. This is happened today. This is happening. Like, Ramaswamy sir, what is your thoughts?
Any other comments? Dr. Nilesh has joined, I think, and he was to discuss the previous case. You want to comment on this one?
Hi, sir.
Hi.
Hi, Nilesh.
Want to
Yeah. Hi, Movin. As Abhijit suggested, there is a possibility of, comorbidities also, and drug was a precipitating factor probably in this case. So.
Okay.
The medicine was being continued, or on a how many days the medicine was given?
Medicine was continued till the day he presented again with the hematemesis to emergency.
Why we did not stop the medicines? Having the patient is having LMH, LMWH as well as dual antiplatelets. Because there was no one which is impending to start the treatment. Hemoglobin was 9.7, platelet is 90s.
Hemoglobin was 6.7. So that coronary event time we stopped, and it got stabilized, and we discharged him after 2 weeks. So that discharge time we send him on again on a drug. And when he came for a review after a week, he was fine. After again almost near a week, he presented emergency. Swami sir, when he had an acute event, we stopped. It stabilized and send him on drug. We thought all settled. Likewise, Abhijit was telling elderly, previous history of coronary event must have precipitated some or another. That's how we were thought. We still thought of we put stent, stabilized this thrombus part is taken care. Hematuria started. We stopped anticoagulation. We put on stent, and along with dual antiplatelet, this hematuria settled, was fine, transfused and stent. He came for a review also a week later. It was fine. The next before the next review, he came to emergency. That's what actually happened.
So dual antiplatelet is also one of the major risk factors for the bleeding during
because
the...
this stent was placed. They wanted to give for at least 2 months of time.
Absolutely.
Then they thought they'll cut down. Once everything settled, we also thought this won't happen. But
Any other comment? Any other experience sharing with Ekala? Okay, then thanks, Dr. Mobin, and we move on to the last case, which will be presented by myself.
Dr. Agarwal, sorry, sure. I thought I was supposed to present my case, so I was waiting for that on acalabrutinib sharing. So I'll just brief. Sorry?
Please go ahead.
Yeah. So I have 2 cases. The first one is a CLL patient with deletion 17p. And the reason we chose to start with Ekala was because he was coming from about 400 kilometers away. and he was also concerned about the side effects, that what if this cardiac effect or these other effects happen when we discussed. So then we told him that there is an option available with a lesser incidence of these potential side effects. And that was the primary reason. His comorbidity was only diabetes. He started the drug and took for about 8 months with excellent tolerance. His platelet normalized from 71,000, and his hemoglobin also improved from about 10.5 to 12.3. But unfortunately, then he stopped due to financial toxicity. So he said, this is now too expensive for me to continue. So he switched to ibrutinib, but his otherwise acalabrutinib experience was good. The other one was a mantle cell lymphoma, a 73-year-old who came to us with after 2 years after B+R. He had 2 years of disease-free interval. And when he came to us, we spoke about at that point R-CHOP versus B+R. And this man had very beautiful silver hair, all white hair. And he was very clear he did not want to lose the hair if there is any option. And so that was the reason. And of course, he had multiple comorbidities, including the hypertension, CKD, history of pulmonary embolism, and CVA. So we started him on Acala, and he tolerated it very well. His spleen reduced in size, cytopenia improved. He took it from May 21 to November 21. And then he had a stroke. He was admitted in another hospital, and in about 2-3 days, he expired. So that's our experience of Acala. There were no day-to-day issues like GI side effects or arthralgias or hypertension, atrial fibrillation, bleeding manifestations, any of those. But both are short, you can say comparatively, about 8 months or so. So that's the experience. The second one, who had a CVA, he had a history of CVA. Now, whether Acala added to that is, of course, difficult to say. So over to you, sir.
Thank you, Chirag. Discussion, comments? Okay, so none, then we move on. And we come to the last case presentation now. So this is about my first clinical experience with acalabrutinib. So this is Mr. Bhatt, 76-year-old, staying at Malabar Hill in Mumbai. He's father of a young, very successful film producer. He was diagnosed to have chronic lymphocytic leukemia 10 years ago. That is in 2012. That time he was 66 years old. After 6 years, that is in 2018, he needed treatment for a progressive symptomatic disease. He was treated by bendamustine rituximab. He had complete response. After 3 years of careful follow-up, he had a symptomatic relapse in late 2021. He had all the systemic symptoms like fatigue, weight loss, and fever. Almost all lymph nodes were enlarged, and the spleen was 4 centimeters. Hemoglobin was 9.2, platelet 85, white cell 160, and 95% lymphocytes. His FISH was bad, deletion 11q and deletion 17p. His IGHV was unmutated, and TP53 was mutated. There was no Richter on biopsy. His performance status was good. He had a number of comorbidities in the form of COPD related to heavy smoking, type 2 diabetes, well controlled, and he had undergone bilateral TKR. He had IHT and had angioplasty with 2 stents. He was hypertensive, but very well controlled, and he had dyslipidemia and was on statins. Professionally, he was very active. He was looking after the finance of his son, working probably for the whole day, and having wonderful evenings, going to club to take moderate quantity of alcohol, playing golf, and even swimming. First time he saw us was with all this information about 6 months ago. And the reason for consulting us was because his relapse was advised to be treated by various different options. And that made his mind very chaotic because there was no uniformity of advice. He received following options. He was told to take chlorambucil monotherapy, saying that he is too old to try anything else. Another consultant advised him that he can go back to bendamustine rituximab because first time it was successful and it was 3 years ago, so it's likely to work again. The third option given to him was bendamustine with obinutuzumab, with the presumption that obinu will do better than rituximab with benda. Another option given to him was ibrutinib monotherapy. And the explanation was very simple, that he has mutations which make chemoimmunotherapy as a contraindication. The other option he received was ibrutinib with one of the MAPs. And again, the explanation given was that the doublet is always better than single. Another option he got was to take venetoclax with obinutuzumab. The idea being that once you use venetoclax, then it's a fixed duration therapy. The last option he had received was all oral therapy, fixed duration, that is venetoclax with ibrutinib. So with this all information, he came to us for the consultation. My opinion to him was entirely different. And I suggested him that he should go to acalabrutinib 100 milligram capsule twice a day. Now, why did I do that? His molecular profile, as we've been discussing the whole evening, rules out chemoimmunotherapy. Giving chemotherapy to a person who has got TP53 mutation, in fact, shortens his life. It allows a lot of mutations to take place. So drugs like chlorambucil or bendamustine are contraindicated once you've got deletion 17p or TP53 mutation. So rather, if you don't treat, the person may live longer than to give them chlorambucil or any other chemotherapy, including bendamustine, which is quite popularly used. So he was left with options between venetoclax, ibrutinib, acala, with or without AMAP. Now, venetoclax will definitely have the advantage of a fixed duration therapy. However, there is enough data to tell you that a fixed duration therapy is detrimental for a person who has got deletion 17p. And from that token, TP53. These are patients who do much better by continuous therapy rather than a fixed duration therapy. So venetoclax is inferior to a BTK inhibitor when it comes to deletion 17p. Now, whenever there is a cardiac condition, and our patient had an overt cardiac condition, having undergone angioplasty, stents, ibrutinib is a dangerous drug. So with all these discussion that chemotherapy-based treatment is going to shorten his life, fixed duration therapy is no good once there is deletion 17p. Ibrutinib should not be the drug of choice and could cause death in a person who has got underlying cardiac illness. Acala was considered to be the safest, most effective, least toxic oral monotherapy. Even today, we are not very clear whether addition of obinutuzumab to Acala really in a long term improves the outcome, and it should be done or not done, though the curves have started separating, and maybe in future we will add a map to Acala, but at the moment it's not necessary. Cancer 2021 publishes this article, chemoimmunotherapy as the first line treatment of CLL. Dead yet, alive, and kicking. So I'm not sure what the faculty over here feels it's dead or alive, but except for a very, very narrow indication where somebody may justify the use of chemotherapy, that is patients who are IGHV mutated and have deletion 13q, except for that small number of people, and if they are young enough to take fludarabine-based therapy, where 35–40% of patients may not relapse and may have a biological cure, but at the risk of getting second cancer, both MDS and others. Overall, chemoimmunotherapy is obsolete in the treatment of chronic lymphocytic leukemia. I understand that bendamustine-based therapy is extremely popular in India, and chlorambucil is still used for old people and poor people. But medically speaking, these are obsolete. They have no advantage over the novel agents. So chemotherapy is a historical treatment of CLL. You can say once upon a time, I used to give these drugs. So that brings us to the druggable molecular targets for CLL. And yes, CD20 is the most exploited, you can say, molecule, which is targeted with one of the MAPs. And then you have these BTK inhibitors, ibrutinib and ACAL. Then you have PI3K, which we don't have in this country, like adalasib. And last is BCL2 inhibitor, the venetoclax, which is available. So coming to the BTK inhibitors, we got two of them available in this country, Acala and ibrutinib. And this question does come up, whether to use Ibru or Acala. And this is a publication way back 5 years ago comparing Acala with Ibru in chronic lymphocytic leukemia by MD Anderson group of pharmacologists. The kin map of 518 human kinases is shown to you on the left side. Acala is second generation BTK inhibitor, which covalently binds to C481. It's from the house of AstraZeneca. Both Ibru and Acala are oral agents. Ibru is given once daily, 420 mg. Acala is given twice daily in 100 milligram BD. Ibru it inhibits many kinases. As against this, Acala inhibits few kinases. And hence, Acala has got less off-target side effects. If you see this cartoon, this is EGFR and ITK. And it's the Ibru which works over there, leading to gut side effects and immune paralysis. If you look at the TEC, though both Ibru and Acala act over there, the inhibition over there by Acala is weak. And of course, BTK, both Ibru and Acala are there. The bleeding is essentially due to TEC family kinase inhibitors. Rash and diarrhea are due to EGFR, and atrial fibrillation is due to CSK. This has been worked out and shown, and therefore Ibru has got all these side effects in a very significant way. So what you see in green over here are very common and significant side effects of Ibru, and we saw that in discussion today. Atrial fibrillation, a common problem. Bleeding, and cases were quoted. In fact, 2 antiplatelet agents are contraindicated when you give ibrutinib, because Ibru itself is an antiplatelet agent. So even if somebody is on double antiplatelet agent, you withdraw one and give Ibru with aspirin or Ibru with clopidogrel and so on. Hypertension, which is ever increasing complication of Ibru, and less common but happen is heart failure and ventricular tachycardia. That's what is shown over here in green and red. If you look at atrial fibrillation, the incidence is double with Ibru than with ACAL. And there was often on mention today of sudden death in patients who are on Ibru. Here is a publication in Blood, ventricular arrhythmia, sudden death in patient taking Ibru. European Journal of Hematology, sudden ventricular fibrillation and death following Ibru. In heart rhythm case report, high-grade heart block associated with Ibru. In blood, sudden or cardiac death in Ibru-based therapy associated with prior history of hypertension or cardiac disease and use of ACE inhibitor. So this is an issue. And I can never forget the case presented by Aswini Hospital in one of the Mumbai Hematology Group meeting, where one single tablet of Ibru was given to one of the soldiers and he died in 2 hours. And there's no other way to explain this except a sudden cardiac arrest secondary to one single ibrutinib dose. This is a research article, real world Ibru, dose reduction, holds and discontinuation in CLL, goes to the tune of about more than 60% of patients in a period of about 3 to 4 years. So Ibru, rash, diarrhea, hypertension, skeletal-muscular pain, opportunistic infection, bleeding and atrial fibrillation. And all this got discussed in last 1 hour. ACAL, yes, rash. ACAL, diarrhea, yes. Hypertension, yes. Infections, yes. Weight gain can happen. Headache is a peculiar side effect of ACAL. We'll come to that because it's a minor side effect and manageable. But if you look at this overall, bleeding and atrial fibrillation, much less with ACAL, especially the cardiac protection is tremendous with ACAL. And the adverse events by ACAL keep reducing with the passage of time. So what you see in the red is the first year. So say diarrhea, 33% of cases in the first year. By the time you are in the 4th year, it is 6%. Headache, which happens to every alternate person, it responds well to caffeine or any other analgesic, 3% by 4 years. And so on, arthralgia, contusions, weight gain, nausea, and interestingly, hypertension, with which Ibru keeps increasing. Here what you see is 13%, 2, 3, and 9%. Look at some of the studies with ACAL in relapse setting, the ASCENT trial. Phase 3 randomized trial of ACAL versus any other, bendamustine, rituximab, or idelalisib, or rituximab. So ACAL monotherapy was superior to any other protocol as far as progression-free survival is concerned. Here it is split up between BR, idelalisib, rituximab versus ACAL monotherapy, and you can see that ACAL monotherapy is superior to BR and IR. What this shows you is the blue and the red line. That is ACAL in 17p or TP53 mutation, or if there are none, it's all superior to any other combination. The same thing over here, blue and the red, ACAL monotherapy in IGHV mutated or unmutated, it makes no difference. It is equally effective. And this is the forest plot showing you that Acala is superior to investigator's choice in all respects: age, sex, performance status, rise stage, bulky disease, number of prior therapy, deletion 17p, TP53 mutation, IGHB mutation status, complex karyotype, and geographical areas. It's superior to all of them. Now, this is ACAL versus IBRU in previously treated CLL patients, phase 3 by John Baird and others. Efficacy-wise, both are identical. If you look at progression-free survival, overall survival, event-free survival, efficacy-wise, both are okay. Same thing shown over here in the forest plot. Irrespective of all those factors, efficacy-wise, both are identical. But when it comes to the cumulative event rates, the blue is the IBRU and the red is the ACALA. The events accumulate on IBRU much more than ACALA, showing you that ACALA has the better safety profile. Now, if a patient is on IBRU, and that we saw today that patients were shifted from IBRU to ACALA because of intolerance, and we have authentic data on that, whether when you are intolerant to IBRU, whether you can move to ACALA. So this is ACALA monotherapy in patients of CLL who were intolerant to IBRU, again by John Baird and others. And the conclusion was ACALA had good tolerability in patients with relapsed refractory CLL who were intolerant to IBRU. And ACALA demonstrated a high response rate of 80% in patients of RR-CLL who were intolerant to IBRU. And these kind of algorithms were there. Frontline BTK inhibitor with or without a MAB. If you are intolerant and if there is an indication to treat, you can go to alternative BTKI. And the failure of that, you can go to venetoclax and rituximab. You could go, of course, vice versa. You can go to venetoclax first and alternate BTKI later. While if it is progression of the disease on a BTKI, then obviously you don't go to another BTKI, you go to the venetoclax-based treatment. And this is what was being talked about by Chirag. Recurrence of IBRU-related adverse events during ACALA treatment. It happens only in about 28% of patients. 72% of patients, the adverse event for which you switched from IBRU to ACALA, there is no recurrence. And if they recur in 13%, it is low grade. In 11%, it is same grade. In 3%, it is higher grade. So overall, ACALA is very well tolerated in patients of RR-CLL who are intolerant to IBRU. And based on this, this is one publication by Mato, all in the family, back-to-back kinase inhibitors in the treatment of CLL. So it's not necessary that you jump from IBRU to venetoclax, you can go to ACALA. Some discussion about continuous therapy versus fixed time duration therapy, that is BTK inhibitor versus BCL2 inhibitors. So if you want to read in the Blood Advances, both views are there by Elizabeth Brain and Susan O'Brien versus John Sieber. Is BTKI or BCL2 inhibitor preferable as the first novel therapy to CLL? The case for BTKI and the case for BCL2. And this is another upfront therapy, the case for the continuous therapy. And one point that I mentioned today, which is firmly established, if you have TP53 mutation or deletion 17p, continuous therapy is better than fixed duration therapy. Don't trust venetoclax in this setting. And I conclude by saying this publication, Advances in Leukemia, Lymphoma, Myeloma, by none other than Paulo Ghia, concluding in United States, clinical use suggests that ACALA is very well tolerated and associated with much fewer adverse events than IBRU, confirming the evidence that was generated in the clinical trials. In other words, if you have a new patient who is eligible for a BTKI inhibitor, then from the angle of adverse effect profile, the drug of choice should be ACALA and not IBRU. So is eyebrow also now history? And are we going to say eyebrow was also once upon a time because of the presence of Acala? I conclude this presentation by saying that Acala is single most effective and most importantly safest of all the CLL drug in our armamentarium in India at the moment. Oral therapy, no risk of second malignancy, including MDS, like you have with fludarabine-based therapy when you try that. It should be the drug of choice for all relapsed settings, unfit patient, poor cytogenetics, as a case of complex cytogenetics was shown today, poor molecular biology, and we saw a number of cases of deletion 17p or 11q, or I would say even newly diagnosed, young, fit, good prognostic patients, because you are giving them then a safest drug with a reasonably long data available. Adverse effect profile makes it superior to eyebrow. Addition of MAB is not essential, unlike venetoclax, and unlike venetoclax, it has to be continued indefinitely. So probably happy days are here again, and I thank you all for listening to me. Again, it's open for now discussion and comments. We now have about 7 patients on Acala for various indications. I've just presented my first patient whom we used it, and the man is going pretty fine. Others are also going pretty fine. We have not had any calamities at all with any patient or any indication.
A lighter note, sir, I feel patient has to be from Malabar Hills. For
Absolutely. You're absolutely right on that front.
You have it?
That's a very, very practical point. If it is 7 patients whom I could give and 70 I could not give, the reason is that. That applies to all of us. Very often you say exactly that situation which you said, that patient Chirag mentioned that ended up with financial toxicity and called it a day. So that's not uncommon that you used it for 2, 3, 4 months and then changed it. But scientifically speaking, the drug is so safe, and these people are so elderly with occult or overt cardiac disease that I think from that angle alone, all other side effect profile is not very important. This diarrhea, skeletal-muscular pain, skin rashes, all these things are manageable. Hypertension occurs with both. I think infection risk, there is no data to show that one is better than the other. The only data is Acala, more headache, and eyebrow, much, much more cardiac events, including sudden death. These ventricular things, they just take you away, finished, over.
In the clinical trials, this was not mentioned as a significant number. But I think over post-marketing, these small is kind of becoming a big number now.
Absolutely, you're quite right.
And it is so scary, as you said, even few cases, it becomes very scary.
Scary. When the first case was presented by Aswini in the MHG meeting, we virtually didn't believe. But the profile was so clear-cut that a guy gets a dose and within 2 hours, he has a cardiac arrest. It was difficult to believe that the two are not related. And then, these case reports and small case series appearing one after other. So ventricular arrhythmias occur. And these are elderly people, and they may have occult diseases. And
my patient was like that, sudden, at home. He didn't get any chance.
True.
This patient from Aswini was a younger fellow, because if he's in the military, then...
So I'm not sure about that, because Aswini treats everybody, the family also. So I'm not sure about that. They were not This was presented by Aswini in one of the emerging meetings, so I will not have details of the age, etc. And this was a couple of years ago. Again, ECALA didn't exist that time. I think this was 6-7 years ago.
So most of the, not most, but a good number of patients in India are younger. So that may be reason why we are probably not seeing that many bad events, or it's just that it hasn't been even probably recognized, not discussed enough.
And you know, in a country like India, sudden death just goes unnoticed. The family never comes back to you to report that event. It happened.
Yeah. Yes, if it is a side effect that lingers, then they would come back to you and say this drug is bad or anything, and we will also register. This we also don't register.
It's not uncommon at all that, you know, somebody is lost to follow up. You don't even remember that he was your patient.
Yes.
Then suddenly you meet some relative somewhere on the shopping complex, and then you recognize that this chap has not been coming to you. So how is he? He says no more. So, and especially if it's a short acquaintance with you, then they often don't bother to inform you. If it's a long case with you for years, of course, they always inform you.
And the elderly, they would also say that there was a heart attack or something happened and he died at home. Yeah.
So, you know, these patients, those who are symptomatic, etc., with oral pill, when they become asymptomatic, disease is controlled, there are no adverse effects. The life becomes like you are managing any other chronic disease in a very effective fashion. Diabetes, hypertension, thyroid, whatever disease you call it. So oral therapy, monotherapy, effective therapy, no adverse events, and adverse events disappearing in 6 months' time makes these drugs wonderful. And most of the side effects disappear. You face them in the beginning, you reassure the patient, you give antidotes, whatever you want, for diarrhea, for skin complications, for muscle pain. And another thing, I mean, I don't know whether you have noticed, muscle pain is much more with ibrutinib than with ECALA. I have not had, after these 7 patients of ECALA, anybody coming and telling me he's got skeletal-muscular pain.
I mean, yeah, 2 of my patients also no other symptoms.
True.
Yeah.
So tolerance profile is much better. Before this meeting,
Is there anywhere anybody has reduced the dosage, because now we are having that ibrutinib dose reduction to 200, 2 tablets instead of 3, and most of the people are using it. In fact, if I'm not wrong, even though
Ramaswamy, that is extremely common. Even if you don't do it, the patients do it. I mean, that's a problem with when you are, you know, you must have seen this with imatinib. 400 milligram, if they're using 100 mg into 4, there is a problem. Using 400 into 1, there is no problem. That is psyche of the patient, that everything he attributes to the tablet, and he reduces the tablet and he's happy. And in CLL, he just looks at the white cell count. He says, even with 2, the count is controlled. Why should I take 3?
There was also some data that after maybe 2 years or so, kind of with the saturation of the BTK receptors, and you can reduce the dose, although not recommended officially by anyone, but
so that data came from Netherlands. They scientifically analyzed patients where they had to reduce from 3 to 2 on medical grounds because of this kind of extensive bruising or severe skeletal muscular pain or blood pressure going up or arrhythmias taking place. So they medically reduced it to 2, and then they had 160 or odd patients who were on long-term 280, and they compared that with patients who were on 420, and they published this, first presented and published that this is equally efficacious, while there is a strong opposition from the others that the resistance development is so common with Ibru as the passage of time, that if you give a subtherapeutic dose, you will end up with more and more resistance, and the duration of efficacy will come down. Okay. So it's not recommended at all to cut down the medicine. Those patients who open out and tell me that they are taking 2, I request them to change over to 3 before they develop resistance.
But it has been shown that even in the presence of a mutation, it is not necessary to change the medications. Of course, there is a chance of failure is there. We don't know what point of that failure will be faster.
Yeah. I mean, again, like TKIs, you don't do mutation studies. Drug is working, that's fine, you continue. So any other discussion?
I suppose if now we have somebody who needs to reduce the dose for intolerance, then at least, if they are from Malabar Hill, we can consider the option of Ecala in those patients.
Yeah, if by some chance you had started Ibru. Yeah. Otherwise, you should not start Ibru probably. Yeah, I see absolutely no reason for an affording patient today. Why should he go on Ibru?
Agree. I think
efficacy equal, and adverse events are much more with Ibru. So if I am a patient and I can afford Ecala, I will be scared of taking Ibru.
Especially those sudden death. The rest, you can even say that, okay, let's start with Ibru, and if things are okay, then continue. If not, switch to Ecala. Even that option exists. But
you keep doing your CT only to prevent those sudden death, isn't it?
No. As I said, barring sudden death, if that was not there, then this would be also a consideration. But sudden death is just, there is,
So no sudden death is now hypothetical.
Yeah, absolutely.
The reality is that there is sudden death.
Enough case presentations on that case reports. So,
and you cannot forget that more than 50% of patients were off the drug due to one or the other reason within a span of less than 5 years. Let's see what happens with Ecala. We don't have long-term data.
Right. Okay.
So we hand over to Dr. Shweta now. It's 9:48.
Thank you so much, Dr. Agarwal. And thanks to all our speakers about Acalabrutinib with us. And thank you so much, sir, to you for, as always, a flawless moderation and presentation. And thanks to all the panelists for adding value to the entire discussion and the audience for their participation. Thanks to the event management team for their logistic support. Thank you, everyone, and have a very good night. Good night. Take care. Stay safe.
Thanks, and bye-bye, everybody. Good night.
Thank you. Bye.